Thanks very much. So questions, please, to any of the panel there. Thank you. Yeah.
So this is Dr. Gosharan Singh. I represent a company called Biocon Biologics, which works for the biosimilars in the immune dermatology space and several other therapy areas. So there have been a lot of discussion on the potential role of biologics in the treatment of pediatric psoriasis. And while the innovative drugs or the innovative biologics, they are approved based on the clinical study, based on the FDA and EMA regulation, the approval of biosimilars is based on extrapolation for the pediatric indication. So what I would like to understand first is that what percentage of pediatric psoriasis patients do you think qualify for biologic treatment? And how comfortable you would be using a biosimilar for pediatric psoriasis to reduce the cost of healthcare in the pediatric patients?
So Amy or Marika? Yeah.
So you're asking about the use of biosimilars for pediatric patients?
Yeah.
Yeah, I don't have any experience with it personally because we don't have them available yet for children in the United States, only for adults. They're only available right now well, I think the TNF-alpha ones, of course, came out first. So I wouldn't have a problem. I'm not going to have a choice when they're available. I think insurance will only cover those. We don't use as many TNF-alpha inhibitors as we do now, the ustekinumab and the Th17 inhibitors right now, and those are coming. So I don't have any experience. Have you been able to use them?
Yes, we use them, but there are many biosimilars, TNF biosimilars, and some of them have citrulline in it, and then the injection site reactions are terrible. So we have to change them back to adalimumab because of the injection site reactions. But now there are without citrulline, and then it's better. But in terms of efficacy, there's no difference.
So what I would like to understand is what sort of real-world data would you expect from a biosimilar to give you more confidence about the use of the biosimilar in the pediatric population?
What is that?
We don't expect that they're going to be different.
Okay.
But as with anything else, we have lots of experience in adults first before it comes to children, but I don't think we're going to see anything differently than what we see in adults. And again, they're going to be cheaper, and we're going to have to use them because that's what we're going to be able to get, right? So I think that's coming.
I'm not afraid of using them in children, not at all. So I don't, like Amy said, we have enough proof that the efficacy and safety is the same. So just look at the side effects and especially injection site reactions, but no problem using them.
Okay, thank you. Thanks a lot.
Yeah, I mean, only if there's an issue with the base, as you talked about. So I don't think we'll have an issue with them. The question is whether when they come out and they're cheaper, at least where I'm coming from, access is all about what the insurance will cover, and whether we'll not be able as easily to get some of the better biologics for our patients because these are available and much cheaper.
Thank you.
Thank you. So question.
Dr. Ravi, I'm Dr. Abhishek from India. So fantastic case and the kind of insight I got from there. Just some of the data which is recently published is basically on interleukin-17, which gives cardioprotective, like there are data to suggest that atherosclerotic plaques also got dissolved with the use of 1 year of interleukin-17. Do you think this is very specific feature for interleukin-17, or any other biologics which will be, or rather even other molecules which will be good to control the inflammation more completely or nearly complete, will have a similar kind of implications in the cardiovascular protectivity?
Thank you for the question. So the answer is we don't know yet. With the research performed, we didn't look at specific interleukins, or we were unable to detect molecular mediators. We used a genetic instrument as an aggregate. Certainly in the field of cardiovascular disease, canakinumab, which is an IL-1 inhibitor, as well as colchicine, have been shown to have cardioprotective effects. But the next step in the research is to identify the molecular mediators. It's possible that IL-17, as well as other biologic targets, may be influential in improving the profile of both cardiovascular disease and psoriasis, but we don't know yet.
Thank you.
Okay, perhaps the last question then. From this.
Thank you. My name is Maria. I'm a medical doctor from Denmark, and I also work with Mendelian randomization, so I just want to thank you all for a very interesting session, and I have a question for you, Avi Ramasur, and it's along the similar line as the question just asked. So I was wondering if you looked at which loci the genetic variants were located in to give an indication of the molecular mechanisms.
Yes, so we did try to dissect the genetic instrument just crudely and look specifically at loci that were involved in inflammation. As you know, there's a difference between loci and genes, so some of these haven't been functionally characterized. We don't know exactly what their function is. Out of the loci that we identified that were related to inflammation, we did see this causal effect, but even when we excluded them from the instrument, there still was a causal effect. So there's a lot of unexplained biology, both within the loci related to inflammation and those outside, and this should form the basis of future work.
Thank you.
Thank you. And one final question.
Yeah.
Thank you.
It's for Dr. Amy Poehler. So what do you prefer for pediatric age group for screening tuberculosis? Like tuberculosis skin test for, you said about doing tuberculosis screening while the pediatric patients are on biologics yearly. So which one do you prefer? Because as we're in country, I'm from Bangladesh, as we're in country where tuberculosis is very much prevalent, so it's not possible to go for or doing tuberculosis skin test, that is Montu test regularly, because we are getting the BCG vaccination. So do you think it is feasible to go for IGRA yearly like that?
So if I understand, you're asking what baseline tests can be done in people who are BCG vaccinated?
Yes, yes.
So I'm going to get Mona to talk in a second here, but I mean, we do quantiferon gold routinely now.
Okay.
Yeah, I think we do quantiferon gold as well, because in our countries, because all of people, a majority are vaccinated with BCG, so they'll have topical positive tuberculin test. So we do the quantiferon gold.
And we can repeat it yearly?
Yeah.
Okay.
Yeah.
Okay, thank you.
Thank you for the question.
We don't have too many in our country who are, but for anybody who has been, that has to be done. And frankly, we're using that for everybody now anyways. We're rarely doing skin testing.
Okay, very last one. Thank you.
Thank you so much for so excellent session. When we most suspect primary immune deficiencies in patients with psoriasis, and which consideration we must to have for treat that patients? Thank you. When suspect primary immune deficiencies in psoriasis patients.
When do we? Okay, actually, I think that in general in dermatology, we face a lot of presentation. We will suspect primary immunodeficiency. So I think mainly when the child has recurrent infections, whether they are general infections like pneumonia, urinary tract infections, or skin infections, and then we proceed accordingly. This child was initially suspected to have different other primary immunodeficiency disorders while in the journey of its diagnosis. It may be severe combined immunodeficiency disorder. We thought he may have IPC syndrome. It's another immunodeficiency disorder. So whenever we are in the entity of suspecting immunodeficiency, we need to consult with the pediatricians, check the labs, and then we find what's possible in the child and suspect again. And sometimes it's not really easy to put your hand on which immunodeficiency the child have. It needs a lot of work. I hope this fulfills the question.
The most frequent immune deficiency are the combined defects or the autoinflammatory defects in psoriasis patients?
Well, just to remind that when most kids who have skin issues with immune deficiencies, and of course there are hundreds of them, tend to have more of an eczematous phenotype or more of a seborrheic dermatitis-like phenotype. So having a psoriasis phenotype, and this looked psoriatic, it was not typical psoriasis or some other features, color, the way the scaling was, but it's unusual to have a psoriasis-like phenotype as part of immunodeficiency. And there are just a few things that we mentioned, like the LRBA and the IPEX, that would be associated. So for the most part, it's going to be more of an atopic dermatitis-like or seborrheic dermatitis-like presentation when we see a young child with immunodeficiency.
Thank you so much.
Okay, thank you very much. So I'll hand over to Lone to...
Yeah. And I just want to close the symposium. I would like to thanks all the authors for the nice presentation, very interesting. And I would also like to thank all in the audience for staying here and have a good meeting. Thank you.